Good evening, everybody. Today's topic is post-resuscitation care. So, the basic aim of this topic is to learn what uh, what are the things that we should take care in post-resuscitation patient. So, first is oxygenation and ventilation. So, as we all know, during cardiac arrest, patients are usually ventilated with 100% oxygenation. So the maintaining saturation within the range of 94 to 98% appear to be appropriate clinical approach. Now the next thing is regarding ventilation. Following restoration of spontaneous circulation, that is ROSC, elevated PCO2 levels are frequently observed in numerous patients, leading to hypercapnic acidosis. So the blood carbon dioxide levels plays the critical role in regulating cerebral blood flow, as we all know. So if the patient is hypocapnic, then it may cause decreased cerebral blood flow, and that this may be associated with the poor outcome. The moderate hypercapnia, on the other hand, may increase cerebral blood flow. So there is a conflicting evidence regarding whether aiming for higher PCO2 will help in reducing brain injury or not. So, targeted therapeutic mild hypercapnia after resuscitated cardiac arrest, that is TAME trial. They randomized 1,800 out of hospital cardiac arrest patient into two groups. One, one is normocapnic and the other one is mild hypercapnic. And the study did not reveal any significant difference in functional outcome or survival rate between these two groups. So the current recommendations the current recommendations are more in favor of targeting normocapnic. The next point is circulation. Ensuring adequate circulation is paramount in the post-cardiac arrest patient, considering its influence on perfusion of the brain, heart, and the other organs. Persisting brain ischemia likely contribute to the outcome of cardiac arrest patient. So after ROSC, blood pressure should be elevated related to the use of adrenaline during cardiopulmonary resuscitation. So uh, hypotension and compromised circulation are exceedingly prevalent in post-cardiac arrest patient and have multifactorial etiologies. This may be due to diminished cardiac function attributable to myocardial ischemia and vasodilatation induced by inflammatory response. So some individual may present with hypovolemia and low blood pressure could be partially due to administration of sedation. So four randomized trials have compared a higher MAP target ranging from 80 to 100 to lower target of 60 to 70 mmHg. The box trial, which was published in 2022 in NEJM to determine the blood pressure for the treatment of comatose survival. And the conclusion of this trial was targeting the mean arterial pressure, blood pressure of 77 mmHg or 63 mmHg in patient who had been resuscitated from cardiac arrest did not result in any significant percentage of patient dying or having severe disability or coma. So recent meta-analysis failed to identify any compelling evidence supporting improved outcome associated with higher MAP target. So the future research should center on investigating whether targeting higher MAP may yield more modest effect or whether specific patient subpopulation might derive distinct benefit from the alternative MAP target. So about ERS guidelines, in 2015, when they have released the guideline, they have set the target mean arterial blood pressure to achieve adequate urine output and normal or decreased plasma lactate values, taking into consideration the patient's normal blood pressure, the cause of the cardiac arrest, and the severity of any myocardial dysfunction. But in 2021 guidelines, they just mentioned we should avoid the hypotension. That is, MAP should not fall below 65 mmHg, and target MAP we should achieve the target MAP that should be the at least to maintain the adequate urine output and normal or decreased lactate. So several studies shows the hypotension is consistently associated with the poor outcome. Hypotension, that is a MAP. If less than 65 mmHg, then that is associated with a poor outcome. Although we have stated a threshold value for blood pressure, optimal MAP target are likely need to be individuals. Now we will discuss about the role of cardiac index. So the low cardiac index is frequently encountered into the post-cardiac arrest patient as expected. So detecting a low cardiac index without direct measurement via pulmonary artery catheterization or cardiac echocardiography can be challenging. So the multiple studies have failed to establish a clear association between low cardiac index and poor outcome. So one study was conducted which demonstrated the sustained elevation of lactate level over initial 24-hour following cardiac arrest is linked to the outcome irrespective of cardiac index. The Neuroprotect trial employs the invasive monitoring, incorporating fluid boluses and inotrope to enhance the cardiac index. But this approach did not demonstrate any influence on the severity of brain injury assessed via MRI or brain injury biomarkers like neuron-specific anoles. So clearly, we can see from this data that cardiac index doesn't have any role in improving the prognosis after post resuscitation. So the role of extracorporeal life support. So another tool to improve oxygenation is the utilization of the extracorporeal membrane oxygenation. So the extracorporeal life support in cardiogenic shock in myocardial infarction trial compared extracorporeal life support to standard medical management. Remarkably, 80% of the included patient had experienced cardiac arrest, and the study failed to reveal any improvement in outcome. And uh, but more to that, the extracorporeal life support was associated with the complication. So, in case where cardiac arrest is imminent or has occurred, extracorporeal life support remains the viable alternative in selected cases only. So what I want to say is this extracorporeal life support does not provide any benefit, but there were more complications associated with the use of it. Now the role of steroid. Steroid might be helpful for mitigating circulating shock or reducing the inflammatory response in post-resuscitation patients. A recent small-scale study involving 100 patients in hospital cardiac arrest investigated the impact of administering 240 mg of hydrocortisone compared to placebo over 7-day period following cardiac arrest. And the study did not reveal any significant disparities in the blood pressure level, cardiac function, or inflammatory response as assessed by interleukin 6 level. So ongoing investigation are exploring the use of varying doses and a type of steroids in this context. Now the next is temperature control. With the reperfusion of the brain, multiple physiological pathophysiological cascade lead to the neuronal death by necrosis and apoptosis, which can be mitigated by mild hypothermia in temperature range of 32 to 34 degrees Celsius. So in 2002, the TTM trial was published after cardiac arrest with shockable rhythm, showed improved neurological outcome when these patients were treated with mild hypothermia, ranging from 32 to 34 degrees Celsius for 34 degrees Celsius for 12 to 24 hours as compared to no temperature control. And the idea behind was that only that if we are maintaining the mild hypothermia, then it will help in reperfusion of the brain because it will help in reducing the necrosis and apoptosis. But in 2013, the TTM2 trial was published, which showed no difference in mortality and the neurological outcome between hypothermia at 33 degrees Celsius for 24 hours in comparison to strict normothermic control at 36 degrees Celsius. So according to 2015 guidelines, maintain the constant, they state what we should do for the temperature management. They suggested we should maintain the constant temperature between 32 degrees Celsius and 36 degrees Celsius for those patients in whom temperature control is used. And it was strongly recommended by them. and moderate quality of evidence was provided. Whether certain subpopulation of cardiac arrest patient may benefit from the lower or higher temperature, and that remains unknown. And further research may help elucidate this. TTM is recommended for adult after out of hospital cardiac arrest with initial shockable rhythm who remain unresponsive after cardiac arrest after ROSC. And it was strong. There was a strong recommendation for this, though the quality of evidence was low. TTM is suggested for patient after out of hospital cardiac arrest with initial non-shockable rhythm who remain unresponsive after ROSC, which was having weak recommendation and very low quality of evidence. TTM is suggested for patient for adult after intra-hospital cardiac arrest with initial rhythm who remain unresponsive after ROSC. It has a weak recommendation and very low quality of evidence. If targeted temperature management is used, it is suggested that the duration of the this should be at least 24 hours. Again, it has a weak recommendation and very low quality of evidence. In 2021 guideline, they just simplified all these things, and they just said we should recommend the targeted temperature management for adult after either out of hospital cardiac arrest or intra-hospital cardiac arrest with any initial rhythm who remain unresponsive, which was much more simplified. That means any patient after achieving ROSC of any rhythm, if he is unresponsive, then we must initiate targeted temperature management and maintain the target temperature at constant value between 32 degrees Celsius to 36 degrees Celsius for at least initial 24 hours. And avoid fever for at least 72 hours after ROSC in patient who remain in coma. So in 2021 guidelines, the things are very much clear and simplified compared to 2015. Now, general intensive care, one of the initial step in post-resuscitation phase involves identifying the underlying cause of cardiac arrest. You should know what is the cause of cardiac arrest, then we can proceed. So recent guideline recommended considering early coronary angiography for patients suspected of having myocardial ischemia. And if coronary angiography fails to identify a causative agent, causative lesion, then further evaluation, including brain and pulmonary angiography, computed tomography is recommended to assess for acute cerebrovascular event or pulmonary embolism. So, regarding coronary angiography, when exactly it is recommended and when we should do it. So, in 2015 guidelines, they have told it is reasonable to discuss and consider emergent cardiac catheterization, laboratory evaluation after ROSC in patient with the highest risk of coronary cause for their cardiac arrest. And in 2021 guidelines, they recommended in patient with the ROSC after out-of-hospital cardiac arrest without ST elevation on ECG, emergent cardiac catheterization laboratory should be considered if there is estimated high probability of coronary occlusion, that is patient with hemodynamic and electrical instability. So in 2021 guideline, they have made slightly change that if a patient has achieved ROSC and he suffered out of hospital cardiac arrest and ECG is not suggestive of ST elevation, but still the patient is hemodynamically unstable and if we are strongly suspected, then we should go for coronary angiography. But again, there are certain recent RCTs which showed that a patient without ST elevated myocardial infarction on ECG and without cardiogenic shock, so we can wait for coronary angiography for up to 5 days after cardiac arrest without additional risk to the patient and cardiac. So after initiating targeted temperature management, what is the role of sedative and NF block? So temperature control is commonly implemented in the management of cardiac arrest. The use of short-acting sedative and opioids is generally recommended to facilitate proper ventilation and prevent shivering. So all the patients undergoing targeted temperature management should receive appropriate sedation and analgesia, usually a low dose and continuous infusion. Between 35 degrees Celsius and 37 degrees Celsius, shivering occurs frequently as a physiological reaction. So why we are so much worried about shivering? Because shivering slows the time to target temperature and increase the metabolic activity. So it should be treated aggressively. Now, the another measure to prevent shivering is the blankets and hot air warmer. To prevent and treat the shivering, a bolus of intravenous magnesium can also help raise the shivering threshold. Increasing analgesia and sedation can also reduce the shivering. If, however, after despite all these measures, if shivering still persists, then neuromuscular blockage can be effective. If patient is not cooling at the rate of 1 degree Celsius per hour, then empirical bolus of neuromuscular blockage may help reduce subclinical shivering and achieve the target temperature more quickly. It is essential to acknowledge that sedatives like propofol can potentially lead compromised circulatory function and significant alteration in brain function, as indicated by burst suppression pattern observed on EEG. Now, what is the role of hemoglobin? So, hemoglobin plays a vital role in tissue oxygen delivery, as we all know. So, therefore, anemia can be particularly detrimental in post anoxic brain injury. So, there are no specific India recommendation for thromboprophylaxis, ulcer prophylaxis, and glucose management for cardiac arrest patients. So regarding nutrition, initiate enteral nutrition early, typically within 24 to 48 hours of ICU admission. Hold particular significance in cardiac arrest patient to avoid malnutrition and preserve intestinal barrier integrity. A recent RCT showed the early caloric restriction was associated with lower incidence of gastrointestinal intolerance, bowel ischemia than standard caloric intake. Okay, so that's the reason that we should initiate enteral nutrition early. That means within 24 to 48 hours. As cardiac arrest patients are at high risk of intestinal ischemic injury and may often with concurrent circulatory failure, a more restrictive caloric intake should be considered in this patient. So patients who have been successfully resuscitated from the cardiac arrest, they are at high risk of lower respiratory tract infection. So the prophylactic antibiotic administration can reduce the risk of early pneumonia in patients with the initial shockable rhythm and treated with the targeted temperature management at 32 to 34 degrees Celsius, but doesn't have any impact on mortality and neurological outcome. Now, how to maintain the blood sugar levels. As we all know, the hypothermia will decrease pancreatic insulin secretion and increase insulin resistance. And the result of it is hyperglycemia. So the blood glucose should be monitored hourly, and the optimal glucose target remains debated. So the no difference in 30-day survival was seen in one randomized clinical trial compared to the tight control. That is 70 to 108 mg per dl versus moderate control that was 108 to 144 mg per dl in post-cardiac arrest patient. There is currently no data supporting glycemic control for post-cardiac arrest patient should differ from any other critical care setting. Though the avoidance of hypoglycemia is a key because it could exacerbate neurological damage. So there should not be a strict glycemic control, but we can avoid the hypoglycemia because it can aggravate that neurological damage and it can worsen the prognosis. And regarding the sugar level, we can follow that normal sugar level range which we are following in critical care setting. So according to the ERS guidelines in 2015 guideline regarding general intensive care management, short-acting drug that is propofol, alfentanil, ramifentanil will enable more reliable and earlier neurological assessment and prognostication. Following ROSC, maintain the blood glucose level at less than 180 and avoid hypoglycemia. And in 2021 guidelines, what they have suggested is we should use the short-acting sedative and opioids, avoid using neuromuscular blocking agent routinely in patient undergoing TTM because it may considered in case of severe shivering during TTM. Provide stress ulcer prophylaxis routinely in cardiac arrest patient. provide deep venous thrombosis prophylaxis, target a blood sugar level between 140 to 180 using infusion of insulin if required, avoid hypoglycemia. Start enteral feeding at low rate, that is trophic feeding, during TTM and increase after rewarming if indicated. If TTM of 36 degrees Celsius is used as the target temperature, trophic gastric feeding rate may be increased early during TTM. We do not recommend it using prophylactic antibiotic route. Then regarding treatment of seizure, we should in 2015 guidelines they have suggested treat the seizure with sodium valproate, levetiracetam, phenytoin, benzodiazepine, propofol, and barbiturate. In 2021 guideline, they suggested to treat seizure after cardiac arrest. We suggest levetiracetam, sodium valproate as the first anti-epileptic drug in addition to the sedative agent. In recently reported trial, valproate, levetiracetam, fosphenytoin were equally effective in terminating convulsive status epilepticus, but fosphenytoin caused more episode of hypotension. So, and due to it is very clear that if if fosphenytoin is causing more episode of hypotension, then we should avoid it because hypotension will again cause neuronal injury, which will cause the bad prognosis. Then the next is electrocardiography. Most common arrhythmia of TTM is the sinus bradycardia. So at cooler temperature, the PR interval will prolong and the patient can experience junctional escape. So rewarming by 1 degree Celsius to 2 degrees Celsius will resolve the conduction abnormality. Cooling can also prolong QT interval, again in dose-dependent fashion, though there is no evidence to suggest it precipitate torsitis deployments. Osborne or J wave may present in up to 20% of patients depending on target temperature. No specific therapy is required for non-life-threatening arrhythmia, but rewarming by 1 degree to 2 degree will resolve most conduction abnormalities. Now return to normotherapy. Gradually rewarming, that is 0.25 degrees Celsius to 0.5 degrees Celsius per hour, should be initiated at least 24 hours after TTM initiation. Rewarming faster than this raises the risk of hypoglycemia, hyperkalemia, hypotension. So once the TTM protocol has been completed, the patient has achieved normothermia. Actively avoiding fever among the patient who remain comatose is reasonable because hyperthermia is again associated with worse neurological outcome in critical care setting. This can be achieved by leaving the temperature management system in place and by use of antibiotics. So phases of targeted temperature management. So whenever we are receiving the patient after ROSC, the first step is cooling, initiation of the cooling, and we are applying TTM only in patient who remain comatose after achieving ROSC state. So the first is initiation, that is start cooling immediately. We can use analgesia, sedation if the patient is shivering. And if we are not controlling shivering after using sedation and analgesia also, then we can add neuromuscular blocking agent. Then we should maintain the temperature between 33 to 36 degrees Celsius for at least for first 24 hours. Then slowly we should start rewarming. Begin after 24 hours, that is at the rate of 0.25 degree Celsius per hour, and then maintain normothermia after that. And after maintaining normothermia, we should take special care that we should avoid the fever because again the high temperature will cause neuronal damage. Now, once we have achieved the normothermia, the next step is the prognostication. So first, now how we should prognosticate. So first, clinical examination is the cornerstone of the prognostication. It should be conducted after ruling out potential confounders like sedatives and the hypothermia. So daily clinical examination is recommended for patient undergoing temperature management with final prognostic assessment conducted after rewarm. So particular importance is given to pupillary and corneal reflex and to the presence of myopia. presence of abnormalities in the brainstem reflex and the abnormal movement should be considered in relationship with the prognostic. Prognostication should include, together with the clinical examination, electrophysiological test, and the assessment of the biomarkers of cerebral injury and the brain imaging. In particular, the presence of at least two predictors of severe neurological injury, such as absence of pupillary corneal reflex at 72 hours, bilateral absent N20 cortical waves at somatosensory evoked potential wave at 24 hours, the highly malignant EEG pattern at more than 24 hours, neuron-specific enolase if it is more than 60 mg at 20 for 48 or 72 hours, then and any episode of status myoclonus suggestive of the poor prognosis. So, according to 2015 guidelines, if one of the following factors are present, then that indicates poor outcome, and which was no pupillary corneal reflex, bilateral absent N20 SSEP waves. If any one of these is present, then we can explain, then that indicates the poor outcome. If two or more of the following indicate, if following factors are present, then that indicate poor outcome, which was, then poor outcome is likely. And those factors were status myoclonus less than 48 hours after ROSC, high neuron-specific enolase level, unreactive burst suppression or status epilepticus on EEG, and diffuse anoxic injury on brain CT or MRI. So in 2021 guidelines, they modified few things and they clubbed everything. Like if when two or more of the following predictors are present, then that indicates straight away the poor outcome, which was no pupillary and corneal reflex at more than 72 hours, bilaterally absent N20 SSEP waves at more than 24 hours, high malignant EEG at more than 24 hours, NSE, neuron-specific enolase more than 60 at 48 hours and 72 hours. Then status myoclonus less than 72 hours. Diffuse or extensive anoxic injury on radiological imaging like CT or MRI. If any one of these, if two or more of the factors are present, then that indicates poor prognosis. So again, we will revise the principle of management of the patient with non-cardiac arrest. So first time should be the identifying underlying cause of cardiac arrest. Then we should take the ECG. And if ECG is suggestive of STEMI, then straight away we should shift the patient for coronary angiography. And if it is NSTEMI and with hemodynamic or electrical instability, then coronary. Then we should shift the patient for coronary angiography. Then about the hemodynamics, we should avoid and treat hypotension. That is, MAP shouldn't be less than 65 mmHg. Consider the MAP target of 70 to 75. Then regarding mechanical ventilation, maintain the normocapnia, that is 35 to 45, and oxygenation level should be above 90. Then regarding targeted temperature management, if a patient is fulfilling the criteria for TTM, then we should initiate the TTM as soon as possible on hospital arrival. Then TTM should be started prior to and continuing during coronary angiography. The target temperature should maintain between 32 to 36 degrees Celsius, and we should maintain this temperature at least for 70 or for 24 hours. And then we should start gradually rewarming the patient. Check the blood glucose every hour. Again, there are no specific glucose HGT criteria, but we should maintain the blood glucose level between 140 to 180, and hypoglycemia should be avoided. Check electrolytes every 4 to 6 hours. The neurological monitoring for the comatose patient, continuous EEG as soon as possible following cardiac arrest. Consider somatosensory evoked potential 24 to 72 hours post-arrest. Neurologic prognostication should be delayed until at least 72 hours post-return to normothermia for patient treated with TTM, or at least 72 hours post-arrest for patient not treated with TTM. Thank you.